Hello, my name is Taylor Williamson, and I'll be moderating today's session on learning about how health systems researchers and practitioners manage controversial and misrepresented results. I'm a vice chair of the Translating Evidence to Action thematic working group and a health systems manager at RTI International. Thank you for joining us on the symposium platform or directly online via the YouTube feed. The Translating Evidence to Action thematic working group is one of 10 Health Systems Global supported TWGs. We focus on the translation of health systems evidence into action through knowledge exchange on best practices, lessons learned, and practical guidance and tools. Our goal is to decrease the gap between public health knowledge and public health action. If you're interested in joining our thematic working group, please join our Google group through the Health Systems Global website. I'm joined today by our chair, Dr. Daniela Rodriguez, an associate scientist at Johns Hopkins University, and vice chair, Dr. Nazreen Jassani, who has appointments at Hopkins and Stellenbosch University. Our session today is structured into 3 parts. First, I'll give a short introduction about controversial and misrepresented results and the implications of those. Then we have 7 storytellers who will be talking about a range of different controversial and misrepresented results and experience that they have had dealing with those. And then we have a 15 to 20 minute question and answer period so that you can ask our storytellers questions directly. So why is evidence valuable for decision making? In an idealized world, evidence, including research, data from routine monitoring and surveys, and even public health opinion polling, provides policymakers with actionable information on which they base public health decisions that in turn influence health outcomes. In this idealized process, researchers ask questions and find evidence that answers those questions. Program managers collect and analyze data from monitoring systems that can help pinpoint emerging issues or differential coverage between communities. Knowledge brokers, such as think tanks or even advocates, then synthesize that evidence for policymakers who finally make decisions that are supported by that evidence. But in practice, we know that evidence-informed decision-making doesn't work this way. Politics matter, context matters, social goals matter. Health systems evidence is not always clear-cut or straightforward. And as health policy and systems researchers and practitioners, we're not always equipped to manage cognitive biases, declining trust in institutions, and politically informed rather than evidence-informed decision-making. As a result, our idealized conception of evidence-informed decision-making is eroding. From high-profile politicians spewing misinformation about COVID-19, to anti-vaccine groups, to my uncle who spreads anti-mask memes on social media. Public health evidence has been losing ground to opinion, misinformation, and frankly, fake news in recent years. So how do we understand this decline in public trust in evidence? Well, recently, an analysis from the RAND Corporation described the decline of facts in public life. And I'm going to share a slide so that you can see how they've described these challenges. There we go. So they've identified 4 trends that lead to the undermining of trust in facts and data. An increasing disagreement about facts and the interpretation of facts and data, a blurring of the line between opinion and fact, the increasing influence of opinion and personal experience over fact, and then the declining trust in formerly respected sources of facts. Those are the 4 trends in the middle of their graphic. These trends stem from numerous drivers found at the top, such as political polarization, which drives disagreement about facts and the blurring of the line between opinion and fact by creating 2 or more opposing sides, which develop insular thinking. Cognitive biases, such as motivated reasoning or confirmation biases that seek to confirm prior beliefs regardless of reality. Third, the rise of social media to spread misinformation. As Mark Twain once probably apocryphally said, a lie can travel around the world and back again while the truth is lacing up its boots. A 2018 study at MIT showed that false stories are 70% more likely to be shared on social media than true ones. And then finally, there are demands on educational systems for students to score well on tests rather than a focus on carefully understanding and evaluating sources and separating fact from opinion. Those trends and drivers lead to the 4 main consequences at the bottom. The erosion of civil discourse is the first one. It's commonly said that you're entitled to your own opinions, but not your own facts. How true is that? If we aren't all working from the same set of facts, then it's impossible to have meaningful public policy debates, and the quality of public health decision-making declines. Second, political paralysis. Disagreement about facts leads politicians to reject compromise and action on important topics, as we've seen with the COVID-19 pandemic. Paralysis results in lapses in oversight and an inability to decide how to allocate resources. Third, it leads to alienation and disengagement of individuals from political and civic institutions. Declining trust in institutions, and especially public health institutions, can decrease civic engagement and compliance with public health mandates such as masks, vaccines, or even anti-smoking laws. Policy uncertainty at the national level is our final consequence. Having a common set of facts means that various stakeholders can have objective data and benchmarks when evaluating policy. Without agreement on those facts, policy uncertainty can constrain responses to crises and affect investments in critical public health infrastructure. As a health policy and systems community, we should be sharing our experiences and data in our fight to bring the best available evidence to the world's policymakers, the public at large, and frankly, other researchers. We should be pushing back against the erosion of evidence as a valuable tool for making public health decisions. In this session, we'll hear from some researchers, journalists, advocates, and public health practitioners who've worked hard to have research, and in some cases, basic facts, accepted by decision makers, other researchers, multilateral institutions, and the public. They have a great deal of experience with the difficulties of presenting controversial research and fighting misinformation. As you listen to our storytellers today, see if you can identify how, or even if, their stories align with the drivers, trends, and consequences of the decline in facts and trust in institutions that RAND identified in their paper. From addressing the anti-vaccine movement head-on, to important questions about refugee policy, to complex debates about payment structures within the health financing community, these storytellers are battling misrepresentation that serves to confuse issues at best or benefit powerful interests working against the public's health at worst. Importantly, our speakers will also address how engaging with politicized evidence use has affected them personally and professionally, opening a window to discuss how we can support each other in one of the inherent challenges in our field. I hope their personal experience will inspire you to think about how you can strengthen your ability to combat misinformation, misrepresentation, and confusion, and develop the skills necessary to bring evidence into discussions of public health. During the presentations, please type your questions into the chat box, and we'll answer as many as we can during the Q&A session after the presentations. And if possible, please address your questions to specific panelists. So first, I'd like to introduce our first three speakers. Dr. Connie Ho is an assistant professor at Johns Hopkins Bloomberg School of Public Health. Her research focuses on the social determinants of non-communicable diseases and injuries, and specifically, she explores industry interference in public health decision-making. Dr. Sakina is our second speaker is Dr. Sakina. She's a medical doctor with 24 years of experience in public health administration across various tiers of the Indian health system. She currently works as a district medical officer at Malappuram District, Kerala, India. She graduated from Calcutta Medical College and has a master's in public health from Sri Tirunal Institute for Medical Sciences and Technology. Our third speaker is Dr. Anne-Marie Turcotte Tremblay, who recently obtained her PhD in public health from the University of Montreal. She's currently a postdoctoral fellow at the Harvard T.H. Chan School of Public Health, and her research focuses on the design, implementation, and impact of interventions that aim to improve access to high-quality health services for vulnerable groups. So now I'm going to turn it over to Dr. Connie Ho to give her story.
Hello, everyone. My name is Connie, and I'm an assistant professor at Johns Hopkins Bloomberg School of Public Health. So I study industry interference in public health policymaking. Specifically, I look at the actions of the tobacco industry, alcohol industry, and most recently, I started looking at the actions of the food industry during the policymaking process. At the same time, I also study how public health advocates in various low and middle income countries combat industry interference to advocate for national policy change and implementation. Why do I do this? Well, I really want to identify innovative and effective tactics and arguments from successful advocacy cases and share them with advocates in other countries. My hope is that they could add these tactics and arguments to their toolbox of strategies to counter industry interference. I was also going to publish these findings in peer-reviewed manuscript to contribute to the field of policy advocacy. Sounds like a reasonable goal, right? Well, that's what I thought. But surprise, surprise, what I thought was reasonable was actually turned out to be quite challenging. So to protect the identities of the 3 countries where I undertook this work, as well as the work of my colleagues, as well as myself, I will refer to these 3 countries that I've worked in as country X, Y, and Z. So in country X and Y, where I conducted this work, public health advocates were concerned that the industry would get a hold of our report and use it against them. In country X, 3 things occurred. 1, we were told to wait before releasing our report until they had completed their most recent advocacy effort. 2, the advocates amended aspects of our report and deleted tactics that they were still using. 3, they asked us not to share sensitive information related to the inner workings of their government. This was not unique to country X. In country Y, where I experienced the most challenge, public health advocates carefully combed through each and every word in our report, deleting what I did not realize were sensitive terms such as lobbying, advocacy, tactics, and anything related to foreign assistance. These advocates were scared. Just to give you some context, during one of our group meetings, they closed the door and asked the restaurant staff to leave, fearing that the restaurant staff were eavesdropping for the industry and or might share the information with the wrong people. They also warned that the report cannot be widely distributed because it will hurt their movement and set them back. This, I thought, probably also meant no manuscript, which of course, as a junior faculty member, is challenging given that we need to publish a good amount of manuscript each year in order for our career to move forward. But I definitely didn't want to hurt any public health movement. That was not my intention. What a dilemma, right? So how do we as academics balance our professional and institutional requirements to publish with the need to protect our partners and an important work that they do? I checked with my director, the donor, and our university's dean of research, and we all agreed that I should not publish. I even spoke with a friend who is a trained ethicist, and she also agreed with the decision, saying that we should do no harm. So in the end, I applied the do no harm principle and did not publish because publishing would defeat the purpose that I initially had, which was to help public health advocates learn from successful cases to counter industry interference. Now, what's the moral of this story? Well, I think for me, there are 2 things. First, I believe that this is just more evidence to show that these industries are way too powerful and that they need to be restrained. Like I said, public health advocates in one of the countries was literally scared. Second, I wish the incentive structure at my university and other similar universities can be changed so that I'm not here telling you about how challenging it is for my career because I can't publish this work. and perhaps in some ways dissuading others from undertaking this type of study. Rather, I would be reflecting on a system that allows me to focus on telling you how inspired I am by these public health advocates who work tirelessly, sometimes, as they say, 24/7, using incredibly clever and cool tactics to protect public health from vested interests. Thank you.
My experience of fighting misinformation in the health sector started from the early days of my training as a medical doctor and is ongoing till today, managing the present COVID pandemic scenario. Since 2017, I have served as District Medical Officer of Malappuram District in the southern Indian state of Kerala. I have been leading district health system efforts to improve childhood vaccination coverage, and I have often had to deal with misinformation about vaccination. The population of Malappuram district was 4.6 million. In 2017, the district had only 57% childhood full immunization coverage, lowest in the state. The district also had witnessed the re-emergence of vaccine-preventable disease, outbreaks and child deaths. Malappuram district for many years was a low performer in immunizing children. Organized anti-vaccine campaigns, religious fundamentalist belief of some groups, and faith in quacks and alternate medical practitioners who assumed anti-vaccine positions were the biggest challenges. The anti-vaccine propaganda groups camouflaged their ideas with the talk about seemingly innocent lifestyle, advice of healthy food, organic farming, etc. The problem is they would circulate conspiracy theories like international drug mafia pushing vaccines for the profit at the cost of third world. Kerala is one of the most literate states in the country with massive digital penetration, which makes it an ideal environment for infodemic. The WhatsApp message of anti-vaccine campaigners carried amplified stories on adverse events, with those of us on the front line knew were mostly minor and temporary discomforts like fever, pain, etc. Another issue of Malappuram district was the household decision-making structure. A considerable number of heads of households are male expatriates, earning a living in countries in the Middle East, while their families and children live in Kerala. Field health staff conduct house-to-house visits and would reach their families in Kerala and could not communicate with the heads of households. Our district health system was already overburdened with inadequate staff and vaccine supply chain issues, and relied on traditional health communication channels like classes and posters. So, even when succeeded in persuading well-educated mothers to accept government-sponsored immunization, they could not persuade their families and heads of households abroad. At that time, a national vaccination drive to eliminate measles and control rubella was announced. To implement the program, we had to convince parents and teachers of 12 lakh children in the district regarding the need and importance of vaccination in general and measles rubella disease specifically. To implement a national priority vaccination drive in a district with recorded vaccine hesitancy is a challenge, but I could sense an opportunity. The state and central governments monitored the program closely, and this meant the various government and non-governmental agencies in the district were accountable for the program success, and their resources could be pooled and coordinated to formulating a robust action plan. Into campaign mode with each of the stakeholders, conducted various activities as well as sessions featuring medical professionals and community leaders. Community outreach using a dedicated Bodhana vehicle and a sticker campaign on the most commonly used transport, auto rickshaw, in rural areas with support of local football celebrities. We reached out to children using art, theatre and music, trained teachers in madrasa. We engaged a special Gram Sabha to monitor vaccination coverage below 95% to develop specific strategies to address resistance and misinformation, and held meeting across line department to reach underserved groups. The misinformation that prevailed proved challenges in some cases to counter. Some schools were reluctant to conduct immunization sessions. We even faced legal complaint against the compulsory vaccination drive. Matters accelerated and eventually the High Court of Kerala issued orders upholding the MR campaign guideline. First, parents not willing were asked to hand over objection letters. Additional sessions and Parent Teachers Association meetings were conducted. Eventually, we could vaccinate 11 lakh children, that is 84%. The momentum of MR campaign helped us with routine immunization. Our coverage improved to 92.5% in 2019. We learned that misinformation and vaccine reluctance can be reduced with the persistence, collaboration, opposing information in established channels, and thinking out of the box to find new channels to spread correct messages. The experience of measles rubella campaign helped me grow as a decision maker. It had taken a toll personally with sleepless nights and never-ending meetings. However, with the support of my colleagues, I could coordinate an effort that would make considering Malappuram a poor-performing vaccine-resistant district a thing in the past. I would continue to approach any adverse situations as an opportunity and start solving it through coordinated actions, evolving by building trust among the implementers and beneficiaries. I am willing to revisit, correct, and repeat my actions, and I feel that's one lesson I learned. My story is about people coming together to solve an issue that affects them.
Bonjour à tous, je m'appelle Anne-Marie Turcotte-Tremblay, je suis stagiaire postdoctorale à l'Université Harvard. C'est un plaisir pour moi de vous parler de ma recherche controversée qui porte sur les conséquences non intentionnelles du financement basé sur la performance. C'est une intervention en fait qui a été fortement appuyée par des organisations en santé mondiale comme la Banque mondiale qui a investi là, vraiment des milliards de dollars pour promouvoir l'implantation de cette intervention-là. Et donc, c'est sûr qu'il y a énormément là, de pression pour les chercheurs, les évaluateurs et les acteurs sur le terrain pour montrer que l'intervention fonctionne et qu'elle est efficace. J'ai choisi de mener ma recherche doctorale sur les conséquences non intentionnelles de l'intervention parce que je me suis rendu compte en fait qu'il n'y avait aucune étude publiée sur ce sujet-là dans les pays à faible et à moyen revenu. C'est comme si le sujet avait été balayé sous le tapis pendant plus de 15 ans malgré là, tous les débats théoriques autour de ça dans la littérature. Donc, j'ai choisi de mener ma recherche doctorale sur ce sujet-là et très rapidement, là, les gens autour de moi ont commencé à me dire qu'avec un sujet comme ça, j'allais pas pouvoir me faire des amis dans le domaine et que j'allais pas pouvoir décrocher des postes dans certaines organisations internationales. Par la suite, notre indépendance en tant que chercheur a été rapidement menacée lorsqu'un des représentants de l'organisation qui finance l'intervention nous a contactés pour nous demander là, de réviser tous les articles scientifiques qui allaient être issus de notre recherche. Évidemment, on a refusé en disant qu'on était des chercheurs indépendants avec du financement indépendant et on a pu faire valoir notre point, mais c'est sûr que ça a laissé un froid entre nous et ce représentant-là. Les gens sur le terrain ont été très accueillants. Le problème principal est survenu lorsqu'il est venu le temps de disséminer les résultats de la recherche parce que c'était des résultats très sensibles. Par exemple, la recherche a montré en fait qu'il y avait de la corruption, qu'il y avait aussi de la falsification des registres médicaux pour augmenter là, les versements d'argent qui étaient faits aux agents de santé. Donc, j'étais vraiment pétrifiée en fait de la réaction des gens sur le terrain si je partageais ces résultats-là. Et je me suis même demandé si c'était sécuritaire pour moi de partager les résultats de la recherche localement. Donc, finalement, j'ai décidé d'identifier là, certaines personnes clés avec qui j'allais partager les résultats de la recherche sur le terrain. Et lorsque j'ai parlé de ces craintes-là avec un de mes collaborateurs qui était impliqué dans la collecte de données, il m'a lui aussi confirmé qu'il avait eu très peur là, à certains moments lors de la collecte de données sur le terrain. Et nos craintes, en fait, ont été confirmées lorsqu'on a appris qu'il y a une chercheure qui a publié un article scientifique négatif par rapport à l'intervention qui a été empoisonnée là, dans un pays voisin. Donc, ça montre que les enjeux économiques sont vraiment importants. La publication des résultats de la recherche a également été difficile. Par exemple, il y a un des co-chercheurs qui était impliqué avec l'organisation qui finance l'intervention qui a finalement décidé de prendre du recul après avoir lu les résultats là, de la recherche. Il y a aussi la revue Health Policy and Planning qui a rejeté un des articles scientifiques et lorsqu'on lisait là, les commentaires des réviseurs, on voyait que c'était vraiment des gens qui étaient intimement impliqués dans l'intervention. C'est sûr qu'on a pu publier les résultats de la recherche dans une autre excellente revue, mais cela a quand même retardé là, la publication des résultats de la recherche. Plus tard, j'ai été invitée à collaborer à un commentaire critique par rapport à l'intervention et après la publication de ce commentaire-là, il y a des collègues autour de nous qui nous ont dit que les co-auteurs en fait, de cette publication allaient avoir des portes fermées autour d'eux. Par exemple, on m'a dit qu'on n'était plus les bienvenus pour collaborer à certains projets de recherche et certains d'entre nous ont même se sont rendus compte qu'on n'avait plus accès à certains ateliers en lien avec l'intervention. Donc maintenant que j'essaie de poursuivre ma recherche en tant que chercheur en santé mondiale, je me rends compte que la sélection d'un sujet avec lequel on peut se faire des amis aurait vraiment facilité là, le développement de nouveaux projets de recherche dans la région, mais je reste convaincue que même si c'est vrai que certaines portes ont été fermées, je pense qu'il y a aussi d'autres portes qui se sont ouvertes et qui vont en fait nous permettre d'avoir un impact encore plus important en santé mondiale.
Thank you, Anne-Marie. Next, I'd like to introduce our final four speakers. Dr. Shakira Chunara is an award-winning independent public health practitioner, bold activist, and Operation Smile ambassador for South Africa. She's currently appointed to the inaugural African Union Youth Council. Second, we'll have Dr. Laura Gauthier, who's an assistant professor at the University of Montreal School of Public Health and a research affiliate of the Centre de recherche en santé publique, Université de Montréal. With a background in public health, political science, and socioeconomics, her research interests lie at the intersection of implementation science, health policy and systems research, and migrant health. Dr. Ferez Khalil is a senior research and learning consultant at the Canadian Red Cross, working on epidemic prevention and control. He completed his PhD in health policy at Masters University with a focus on supporting the use of research evidence to inform decision-making in crisis zones. Ferez has expertise in medicine, health policy, health education, knowledge translation, and health emergencies, working with relief and intergovernmental organizations. And finally, we have Irene Rodriguez Salas, who's a Costa Rican science journalist based in San Jose. She has a master's degree in public health and health management, and she's a staff writer for La Nación, the largest newspaper in the country, where she fights pseudoscience and misinformation. In her words, good journalism is the treatment against fake news.
Around 2017, post my PhD, there was a slight shift from a purely health policy and systems environment into sexual and reproductive health, away from the pure research environment into the advocacy space. And I had a very energetic executive director who would throw around terms, and many of us do in global health as well. And one of the terms was CSE. Of course, at the time, it was quite foreign to me. So I wrote it down, Googled it, and that was my introduction into comprehensive sexuality education, which is part of young people's curriculum within schools. And, working within the advocacy space, I had also been involved in various religious gatherings across the continent. And I began to learn how important it is to engage religious leaders within communities to get buy-in for your programs, to drive your programs. And on the African continent, you'll find that even governments engage religious leaders in plans for their programming. And so I wasn't expecting much when I received an invitation from UNESCO and the South African Department of Basic Education as a young leader to attend this gathering on CSE. Of course, I've noticed that over the past 2 years or so, there was this growing concern in mainstream media by religious stakeholders, parents, and teachers that government would be teaching children pornography and promoting sexuality, but I didn't really, understand the magnitude of this movement against CSE until this very meeting. And CSE is essentially based on the evidence. And the first day of this meeting was great because it introduced to us how South Africa is a progressive country. We had same-sex marriages approved many, many years ago. Based on the evidence and because of the high HIV burden, high levels of teenage pregnancy, CSE was introduced and adopted into schools. And essentially the amendments to CSE were quite interesting to understand. And again, they were based on research, based on the evidence, what young people want to know, what they need to know, and young people will find this out anyway. And so it's important for us to be able to ensure that they get the right information. And government's plans essentially included that CSE focuses on gender inequality, understanding the concept of gender, understanding human rights, understanding discrimination. And so CSE is not just about pornography. It also teaches young women to know, or young children to know, when they violated, how to report it, what to do about it. I remember many years my CSE involved learning about anorexia and bulimia, for example. And so when you attended this, this first day of the meeting, as a young person, we immediately understood the value of CSE and also what government is trying to do. And on the next day, which included the religious stakeholders, there were swarms of religious stakeholders which came through. Actually, even those who weren't invited came through. Many people came through. The room was eventually closed. The government had begun to explain CSE, and let's just say I was very blown away, because I understand South African society to be quite progressive, and the SADC region in general, which is Southern Africa. And there were these groups, the anti-CSE groups, and South Africa is a diverse country, so we have Muslims, Hindus, Christians, Jews, and the arguments that were made included speeches and preachers and how we would be sinful and we'd never go to heaven. And then there were also arguments around, which included terms like hallelujah and what is the government doing. And they had legal representation. They had parents and teachers who were part of these groups. And many of us youth sat there being like, is this the 21st century, And I think for me, a turning point at that gathering was when a colleague of mine stood up, Mandisa Kanile, and she's a GBV survivor in South Africa and a resolute activist. And she stood up in that room after all of, these inputs. And she essentially said that, as a young girl, she was molested. And she wishes that she was taught at school to know that this was wrong. She wishes she was taught how to report it. And I think that's the point of CSE, is how do our young children learn what they need to know. What's interesting is I don't think that there's any sort of concession in sight by the anti-CSE movement. I think if anything, it's growing. I think there's also, we can understand religious beliefs, etc., but there's also a misunderstanding, or there's assumptions about CSE which are not correct, because as I said, it's not just about pornography. Ending off, this is a very interesting, controversial issue to follow in South Africa around what our young people need, want, and versus what religious leaders, parents, and teachers think they need and want.
Hi, my name is Lara Gauthier, and I am an assistant professor at the School of Public Health of Université de Montréal in Canada. 4.5 years ago, I was designing my PhD research proposal. One of its major components was an analysis of the influence played by a global health community of practice in policy diffusion. I specifically looked at whether and how they had contributed to foster the diffusion of a health financing policy in sub-Saharan Africa. I wanted to engage this community of practice members using a participatory approach. So I met multiple times with the facilitator of this community of practice, and I will be using the abbreviation COP for the rest of my talk, together with some of its most active members, at the time when face-to-face was still possible. And during those meetings, we were discussing and refining the research design as well as preliminary findings as they emerged. I thought that such participatory approach would create a space for open discussions on the research orientations and allow participants to feel included in the research process and analysis. And I thought that this might avoid any risk of ensuing misunderstanding about the findings presented. Well, my assumptions and strategies for research partners' engagement didn't exactly get the results I expected. Our mixed methods research design included a social network analysis of the COP's online forum active members, as well as a semantic analysis of their online posts on the forum for a period of nearly 7 years, as well as a thematic analysis of interviews with key informants and COP documentation. The COP's online forum, as well as other activities of knowledge production, promoted knowledge exchange between experts of the health financing policy of interest. The numerous African members joining the COP benefited from participating in such knowledge exchange because they could not only obtain more knowledge about the policy and its implementation in practice, but also more visibility and access to job opportunities posted on the forum. Therefore, those exchanges contributed to validate African members, and such increased visibility and validation of expertise was the key ingredient that fostered the diffusion of the policy on the African continent. That was the key finding of my analysis. But when the time came to share the draft paper for this study, some of its findings raised criticism from COP members. Some of them criticized my description of the process through which the validation of the African expertise happened. Their image was that of the COP putting forward Southern voice and African practitioners' knowledge in particular, thereby reflecting their social construction of the COP. My social network analysis revealed actually quite the opposite, that the COP primarily diffused North-based knowledge and standards and was actually led by North-based members, although their prominence tended to decrease with time. I think that from the beginning, COP members thought that someone looking into the COP through such participatory process would serve to validate their own social construction of the COP. That my research would confirm what they believed to be true about the world of the COP. But that is not what happened. My research captured a very different view of the COP dynamics, a different truth, also possibly socially constructed, of course, but a different one. And at the time, I wasn't sure how to go about such criticism. With the support of my PhD co-supervisor, and I'm thankful for her wise advice, I explained what the original purpose of my work was and how I reached to those conclusions. And I defined areas for change in agreement with our comments, for example, nuancing some statements in the paper. But I also drew a line as to what was possible to change at that stage. I shared the revised version, but I never heard back from them. Looking back, I think members of the COP expected co-production of the research, but because this study was for my thesis and because I was pursuing an academic career, I had to take on the role of an independent researcher. So I assumed that they were disappointed because their expectations entering the process were possibly not met. But what I learned from this story is that the way we define situations, here a research on the role of a COP, shapes how we experience them. And hence it shapes how we may end up with very different views of the same phenomenon, which was the case for this paper. The paper reflected my own social construction of the COP, which was in conflict with the members' own social construction of the COP. As independent researchers, when engaging with research partners, we need to find the time to sit down and discuss the goal of the research and what angle would be pursued, including possibly a critical yet constructive angle based on evidence, of course. And that's not an easy task. Clarifying from the beginning our expectations as researchers, as well as the expectations of our research partners, is essential. I know that this is what was missing from my research process, and this is nothing new. This experience is, I think, a simple reminder of what constitutes a healthy foundation for any participatory research process. Thank you.
Hola, mi nombre es Irene Rodríguez Salas y soy periodista de Ciencia y Salud de la Nación de Costa Rica. Enfrentarme con la desinformación, las pseudociencias y las noticias falsas es pan de cada día desde hace bastante tiempo ya. Pero ha habido varias lecciones a lo largo de mi carrera que me han enseñado cómo puedo aprovechar lo que sucede a la hora de que se comunican pseudociencias para con buena información y datos poderlas enfrentar. La primera historia que recuerdo, o tal vez la primera que más me impactó, fue hace tal vez unos 10 años, en una enfermedad que realmente representa un reto y algo realmente devastador para algunas de las personas que lo viven. Me refiero a la esclerosis múltiple. En Costa Rica se comenzó a ofrecer una llamada terapia de la liberación, así le decían. La ofrecía una clínica privada, pero no era hacia costarricenses donde emprendía su foco, sino más bien hacia personas extranjeras que estaban con esta enfermedad y con sus consecuencias y viajaban en paquetes de turismo médico. Ya se habían hecho varias advertencias. Ya Fiscalía del Colegio de Médicos de Costa Rica había dicho que había algo que no sucedía, que no estaba correcto, que se estaban ofreciendo falsas esperanzas hacia algo que no iba bien, que realmente no había una cura definitiva o probada para esta enfermedad y se estaba ofreciendo, tal vez no como una cura definitiva para la enfermedad, así no se promocionaba, pero sí como algo que les iba a dar calidad de vida, en lo que ellos creyeron ciegamente y se venían aquí. Hice una nota grande, un reportaje en internet que abarcó video, abarcó gráficos, abarcó textos explicativos y entrevistas con múltiples personas para advertir que esto estaba sucediendo. La clínica en donde esto se practicaba contrarrestó todo lo que pudo. A través de publicidad, a través de sus redes sociales, trató de decir que esto sí era una esperanza para estas personas. Desgraciadamente, poco menos de 2 meses después, una persona, un hombre canadiense de 28 años, falleció en Costa Rica después de haber sido sometido a esta terapia. Yo debo decir eso, yo estuve devastada. Mi editora de ese entonces me apoyó muchísimo, pero sí fue algo muy duro de vivir. Y en esto mi primera lección fue, siga haciendo lo que está haciendo y apoyándose en la ciencia para que más cosas como estas no pasen. Otra historia que recuerdo tuvo que ver con la vacuna contra el papiloma humano, que en Costa Rica se comenzó a hacer obligatoria el año pasado, en 2019, para niñas de 10 años. Sin embargo, aquí el movimiento antivacunas que venía desde otros países comenzó a hacer mella, específicamente porque había personas que tal vez no estaban en contra del resto del esquema de vacunación, pero sí en contra de esta vacuna en específico. Y comenzaron a decir que podía esterilizar a las niñas, que podía causar efectos graves en su salud y le pedían a los padres de familia no vacunarlas. Les pedían llenar cartas para que el Ministerio de Salud no las vacunara a ellas en específico. E incluso una universidad trajo a una médico desde Argentina para hablar acerca de por qué esta vacuna no debía aplicarse. Lo denuncié a través de mis trabajos y debo decir que sí, recibí muchísimos correos de odio de personas que me decían que yo no era profesional. Sin embargo, sabía que la evidencia estaba de mi lado y que años de estarse aplicando esta vacuna, que comenzó incluso a probarse en ensayos clínicos en Costa Rica, se sabía que podía funcionar y que era segura y era eficaz para estas niñas. La vacuna ya se aplica. Ya está dentro del esquema de vacunación en Costa Rica y realmente esas voces de odio fueron acalladas. Esas voces de odio que inclusive acudieron a la corte para pedir que no se les obligara a vacunar, tuvieron que vacunar a sus hijas por un asunto de salud pública. Y bueno, 2020 llegó y con él llegó una pandemia y la pandemia nos cambió a todos el panorama, comenzando por mi trabajo diario. Aquí desde la redacción de La Nación, si ustedes pueden ver, estoy prácticamente sola. Yo trabajo desde mi casa y solo vengo aquí para ocasiones excepcionales como la grabación de este video. Y sí se ha dado todavía mayor cantidad de desinformación y de pseudociencias. Y esto muchas veces sucede porque desgraciadamente en Costa Rica, así como en otros países, no hay una cultura de preparar a los periodistas para cubrir ciencia o salud. Entonces, ¿qué sucede? El 29 de febrero pasado, antes de que llegara el primer caso confirmado de COVID-19 a Costa Rica, se comenzó a dar una falsa información en cadena acerca de que había 2 mujeres con coronavirus y que ya había llegado la COVID-19 a Costa Rica y se hizo un escándalo. Muchos colegas se apresuraron a publicar. Desgraciadamente ellos no tenían la formación para saber que coronavirus hay muchos y de esos había probado ya 7 en seres humanos. Estas mujeres tenían una infección por coronavirus endémico del que causa resfríos y catarro, pero el no tener el conocimiento específico en ciencia y salud hizo a muchos colegas míos caer en esto. ¿Por qué? Porque hay redes sociales tratando de brindar información falsa, pseudociencias y de asustar a la gente para decirles que lo que está sucediendo con la pandemia no es tal. Y a eso nos hemos tenido que enfrentar. Y a eso me enfrento yo todos los días. A poder decirle a la gente con base en datos y con base en ciencia, esto es lo que está sucediendo con la COVID-19 y así es como usted tiene que cuidarse. Esto es lo que sabemos hasta el momento. Todavía seguimos aprendiendo todos los días, pero estas son las herramientas que tenemos a mano para cuidarnos como población. Y las lecciones que he aprendido hasta el momento son las mismas que viví con la terapia de liberación, las mismas que viví con la vacuna contra el papiloma humano. Son esas que te dicen, siga estudiando y estudie mucho. COVID-19 me ha obligado a estudiar como nunca en la vida, pero es la mejor forma de combatir la desinformación y las pseudociencias. Muchísimas gracias.
Hi everybody, my name is Ferez Khalil and I'm a health policy researcher based here at McMaster University in Canada. I want to share with you a story back in 2009 when I led research as part of my PhD doctoral thesis on the Lebanese and Canadian province of Ontario governmental health policy development for Syrian refugees. What I wanted to find out, my research question was around whether research evidence was used to inform the policy development process to address the health needs of Syrian refugees. At the time, Syrian refugees or the Syrian refugee crisis has really took center stage with a massive influx of Syrian refugees in both the Lebanese context but also here in Ontario. When I first started my research work, I asked policymakers, did you use research evidence to help inform your decision making? And almost always the first answer is absolutely. All our policies are based on best available evidence. But it was only after I started digging deeper that I realized that actually none of the policies really used research evidence explicitly, but rather that political factors really helped push forward the development of those policies. Now, this was considered to be controversial for many reasons. Governments don't want to admit that the policies was actually not based on research evidence, and that rather political factors really helped mobilize this idea of developing policies to address health needs of a very vulnerable population. Personally, I was very afraid with repercussions resulting from making statements around limited use of research evidence to inform a health policy for a vulnerable population that at the time was generating massive media attention, both domestically in Canada and in Lebanon, but also just globally. And the decline for interviews from some stakeholders when they knew that I was inquiring about whether they used research evidence really alarmed me that I will end up with having no one to interview to ask about this. What it required from me was to reposition my study and really try to focus on those political factors that help propel the policy development process for Syrian refugees. It's quite understandable that policymakers will be afraid to sort of make statements that say that there was limited use of research evidence, partly because we need research evidence to help sort of validate some of the interventions we're putting forward. And I think that the big lesson for me out of this whole initiative was that when we're conducting research that has sensitive content or that can implicate some stakeholders, it's very important to develop a trustworthy relationship early on, to identify the policymakers and stakeholders that the purpose here is not to expose governments, but rather to get better at a place where we can help policymakers who work in addressing the health needs of vulnerable population in using research evidence at the best of their ability to help inform aspects of the policy. There is no expectation that research evidence will be the only input in informing the decision making, but rather that research evidence is one input among other things or other types of information that can help inform decision making. Now, my study has actually generated quite a massive amount of media attention, both print and radio coverage, and that's when I started being very alarmed at whether the governments that are the policymakers that I interviewed from the respective governments would raise issues with the finding. Luckily, I had incredible support from my research committee and colleagues who helped me navigate any potential issues, primarily around sticking to the data, making sure that I stay as close enough to the data generated from the study. And the lessons I learned is that first, expect the unexpected when conducting research, especially around how to adapt to the unexpected. And second, the idea that you need the in, or as we call it in Arabic, the wasta. And what that means is that people are more likely to speak to you if you've been referred by a credible source, especially policymakers who are in very sensitive political positions. And finally, my big learning lesson from this is that people define research evidence differently. That was a huge learning lesson for me that still guides my career and my professional development now. I realized during the study that expecting everyone to agree on a standardized definition of what research evidence is actually not realistic. To address this, I actually started every single interview with a clear definition of how we define research evidence to help establish sort of a standardized baseline for the conversation. Finally, I want to say that I don't actually regret my experience because it really taught me about myself as a researcher and the skills that you need to be adaptable and flexible when conducting research with sensitive policymakers on a very sensitive key issue. Thank you, everybody. And if you have any questions about my study, please feel free to reach out to me directly. Thank you so much.
Thank you to all of our storytellers today. I want to remind you that we have our question and answer session open. Please go ahead and ask your questions into the Q&A box and into the comments forum on YouTube, and we will get to your questions as soon as possible. So we have 2 questions already set up, and I'm going to ask them in the order in which they came in. So first, this question is to Connie Ho. The question is, that the question asker can completely relate to the dilemma of a do no harm to movements, but what about the beneficence principle? How do we share these strategies? So Connie, would you like to take a chance to reply to that?
Yes, absolutely. Great question. Thank you so much. Right. The intention was so that we could share these tactics with other advocates and they would have different tools to counter the industry. So because of everything that happened, yes, we pursued the do no harm route, but we are trying to figure out alternative ways to share this information. So one thing that did happen is one of the think tanks that kind of work on the initiative with us was training their grantees working on tobacco taxation. And so we shared the results directly with these grantees who would be potentially using these strategies to counter interference. So I think trying to be creative in the ways we disseminate is helpful. Thank you for that.
Thank you, Connie. And could I ask that all of our panelists turn on their videos so that we can see everyone, and it's a little bit more like we're doing it in person, even though we're not, and we're all spread out all over the globe. Thanks. So this next question is for Anne-Marie and Laura. And the question is, to what extent are we ourselves as academics, or rather as an academic community, responsible for the politicization of research? By focusing so much on policy relevant research, action research, policy recommendations, are we responsible for the blurring of lines between science and policymaking? The question asker goes on to say that he's felt implicit pressures from both opponents and proponents of performance-based financing, and that the politicization of research in general isn't very productive to research. So if you could give your thoughts on sort of like the politicization of research, like how we as academics or as researchers can engage with sort of that policymaking process, and especially related to your experience with PBF.
Thank you, Dimitri. That's a really interesting question. And it's true that there's a lot of pressure on researchers to increasingly take part into policy making. We can even see it with funding agencies, that they're increasingly asking researchers to really try to apply their research results to really inform policy making. But I do think that there are some criteria for rigor that researchers really need to focus on. So that's one of the things that I tried to do in my own research, was to really always come back to those criteria for rigor and make sure that that I respect them throughout the entire research process. I do want to say though that I think that controversial research is actually a good thing. So we need controversial research because that's how we'll grow and that's how we can improve. It's through debating these ideas and these results that we can really have a greater impact on the health of the population. So I don't think that debate is necessarily a bad thing. I do think that one really key aspect in order to resist pressures is to have independent funding. So that was one of the aspects in my research that really allowed me to resist pressures from really large international organizations that have a lot of power. So I think that it's really important, especially in program evaluation, to maintain independence of funding and our independence as researchers.
Laura, would you like to add to that?
I have very little more to add. I think Anne-Marie summed it up really well. I think that's a really important question, and I think most of us global health researchers face this question that is, trying to evolve in between the world of advocacy and the world of research, and I think PBF was an excellent example of that, and I also completely agree with Anne-Marie in that she was saying that if we are rigorous researchers and use rigorous methods and share our findings in an open and transparent way. I think that's the best way for us to be able to have credibility and also discuss with possible opponents and proponents of policies. Thank you.
Do any of our other panelists have thoughts on this topic? Because I think it kind of gets to the heart of some of the challenges that we all face when we deal with controversial results.
So if I could just weigh in quickly, Taylor, when we're talking about the politicization of research, it's quite interesting in South Africa, because what you usually find is that you do the research, for example, on comprehensive sexuality education, and it won't be accepted by governments across the continent. But in South Africa, because we're progressive, the government actually accepts it. And even though it's going against the narrative of what's popular, they're still trying to forge ahead with it. And I think this is a very interesting sort of scenario. Whereas, when it comes to politicization, you often find governments are sort of against it. So I think that's interesting, and it's sort of like light at the end of the tunnel, that sometimes controversial results can still be taken on board because it has excellent effects for the population.
Yeah, that's a really good point with, South Africa's government, and in some ways, South Africa's government and their population are at odds around, some of those more controversial issues like comprehensive sexuality education. It's interesting. Dr. Sakina, I have a question for you. On your vaccine work, what do you think allowed misinformation about vaccines to become so widespread? Was it some level of cognitive biases with people? Was it the spread of information through like WhatsApp groups or something similar? Like, what do you think led to some of those challenges that you were facing regarding vaccines?
Actually, the social media challenges were there. The messages, information flowing through social media. Then in the community also, the people had all the misinformation circulating in the community, but the narratives of so-called evidences from internet, newspapers, etc. And even somebody presented as live examples. But when we collectively, with all stakeholders, clarified their doubts, and administrators supported us with the relevant orders and IEC and all, they believed in science, changed their views. And I think misinformation are there in other countries also. And we worked with the children, and working in campus made success here, created solidarity. And now COVID made the context different, achieved more trust in health, and now they are expecting vaccine. These people are asking whether vaccine coming for COVID, what is the efficacy, how much protection they will be getting from the vaccine and all. So sustained efforts and integrating all stakeholders and clarifying their community's doubt and all helped us. And I think to identify what is needed in the particular context you are working in, and what you can contribute within that context is important, especially when you are an administrator. So we utilized all available resources effectively, timely, and we met all stakeholders and also convinced all stakeholders by continuously sensitizing them. Team building and finding a good network is also really important.
Thank you, Dr. Sakina. Does anyone else have thoughts on how misinformation about a specific topic allowed it to become widespread? I think, Irene, you probably have some experience with that, don't you?
Absolutely, but I would like just to get back to what Dr. Sakina was saying about vaccination and what's happening when WhatsApp groups tend to disinform people on certain topics. What happens in Costa Rica is we have a huge good story of vaccination, childhood vaccination mainly, but what happens when it gets to HPV vaccine is that it is a sexual related thing. And I think also Dr. Shakira has spoken of it. When it is just sexual education meeting vaccination, it is just the kind of a twist there, because they're telling, okay, vaccination is good. It's absolutely good. But what happens when you are giving it to 10-year-old girls who are not supposed in a certain Catholic country as Costa Rica is to be in sexual lives? So what's happening? And people were saying, well, maybe the vaccine is good, but what at a young age? Should vaccination be given afterwards? So it was a push and pull to tell people, no, we're not getting 10-year-old girls into bed right now. We just need them to have the vaccination before. But it was just such a pull and pull between conservative people and conservative issues that were telling, no, it is not time for these girls to have their vaccines. But it is also a matter of we need information, and that's also something that is happening right now with COVID-19 vaccines. That we already signed 2 agreements with 2 vaccines companies, and people are just afraid of the process. So we need good information in order to people to know what they are taking and to be confident and to be sure that they are getting their good vaccines. And even though we have a really rushed time, it was with all the requirements, and vaccines are getting all the requirements done. So yes, we need to address and to tell people that with good information and with reliable information, we need to just begin silencing all those WhatsApp groups and Facebook groups and YouTube videos. It is really, really difficult to do, but we have to do it.
Shakira, I'm curious if the experience with the HPV vaccine that Irene mentioned rings true to you with your experience in South Africa.
Look, again, I think South Africa is one of the nice countries when it comes to sexual and reproductive health. There's so much of information. Government really rolls things out there. They're excellent on that front. But it's just to tie to what Irene was saying. I think what's so interesting is that on the one hand, we're sitting with religious beliefs and conservatism, and we're sort of saying, let's not give our girls this. And that's the reality across most of the context. And it's so interesting because I was engaging a few young people via discussion yesterday. And what are the consequences of if we don't do this? And if we're not providing the right information and the right sort of interventions, young girls were saying that if they don't have access to contraceptives or if they're afraid of contraceptives, they're actually mixing Coca-Cola and Disprin. And they're thinking that, for example, is true. A group of girls were telling me that this is trending at the moment. So if you mix the two, you're able to prevent pregnancy. So I think that's really serious. And that's where our role and our evidence and our research has got to come in.
Yeah, that's really fascinating, Shakira. That's definitely a little surprising to me to hear. Moving on, I want to turn to some of our other panelists. So, some of the controversies that y'all have talked about are a little bit more private in nature. So, for example, some of the issues around the PBF or the Chief Community of Practice that Laura talked about, or PBF that Anne-Marie talked about. And I kind of want to dig into those sort of like the private nature of controversy a little bit. And so I'm going to turn to Ferez. I'm going to ask you a little bit about your conversations with policymakers around refugee policy. Like, how did those conversations go? And then obviously those conversations became public. So how was that? How did you navigate the various tensions that you faced in those discussions?
That's a great question. And hi, everybody. I didn't get the chance to say hello to everybody. So it's great to join you all and the panelists and the stories. It's actually the first time I hear the stories. And so it was incredible to just sit back and listen to all the panelists' incredible stories. So thank you for including me on this. To answer your question, it's actually been one of the biggest things that I've been reflecting about since sort of I published the work. So to answer it, refugee crisis in a country that's highly politicized, like Lebanon is, where my work has been, it's a very tricky and sensitive topic to address. First of all, policymakers are accountable to the government head. And so they're very worried about losing their position if they speak about a sensitive topic. Yet alone, Syrian refugees, because the influx of them to Lebanon has caused such a strain on that health system and a competition for resources that it became a question whether those policymakers were willing to talk. So one of the things I shared in my learning lessons in my story was this idea of, as we call it in Arabic, wasta, or the end. You need that connection. I found that at the beginning, policymakers didn't really want to talk to me because the minute I said, I want to talk to you about the health policies for Syrian refugees, it's sort of a guard came up and they said, is this going to get me in trouble? Like what I think was going through their head, and actually one of them did admit it to me, is that, is this going to cause me to get fired, or is this going to cause a public reaction? Because there's one thing about policy and world, but there's also the public perception. If those findings come out where we do in any way state that Syrian refugees have taken more resources from Lebanese people, that would have caused a much more big political situation that none of us could handle. So it required me to think on the spot. And one last thing I'll say about this is that one of the reflections I had after doing my story is this idea of language barriers. And the reason why I bring this up is because, I interviewed people in Ontario, in Canada, policymakers, but also in Lebanon. My study was conducted in English. My ethics approval was that my interviews will be conducted in English language. When we checked about the policymakers in Lebanon, they could speak English or not, we were assured that all policymakers in Lebanon will speak English. When I got to Lebanon and I started wanting to conduct those interviews, although they could speak English, they wanted to speak in Arabic. And then the big problem is, how do you convince those are bigwigs, they're like heavy policymakers, to say, I'm so grateful you're giving me this interview that took almost a year to get. And now I'm asking you, can you please speak in English? Because otherwise I can't use this data. And so that also element is something that I never spoke about till today, actually. I thought of it as one of our panelists was saying her story in Spanish. And it got me thinking about language. And I was like, oh my God, I remember how difficult it was to stop an interview and say, I'm so sorry, we can talk in Arabic because they see me as an Arab, they identify with me, they're willing to give me that space. And then when they speak in Arabic, I noticed it was so different than English. And it was a matter to uphold the ethics approval. I mean, we have very strict ethics application in place that you have to speak in language. So that's another thing that I had to be very careful with. Sorry, Taylor, took a long answer to a very simple question.
No, that's great. And actually, I think Connie has some experience with like what you mentioned around an in, and I wanted to turn to her to get her experience with that because I think your work on the anti-smoking stuff was really relevant to that. So I'm going to turn it over to you, Connie.
Thank you. Yes, absolutely. That resonated quite well with me too. So we also, to understand the tactics used, also interviewed some government officials, and to get that in was quite difficult. Thankfully, in some of the countries, we have local partners who are able to connect us with these high-level decision makers. But then in other countries, even when we have local partners, the governments are just very, very closed off to outsiders. And so that became difficult to not be able to capture their perspective. And thinking about language, since you brought that up, I also remember conducting research, a study with policymakers, interviewing them, and them telling me that they can speak English, but actually finding out that not so much. So that became quite a barrier. But that into getting access to these high-level decision makers to really understand what has happened in the policy process is so critical.
Can I just add one last thing? Sorry, it's not, just want to be clear, it's not just about the Middle East, huh? Like I also faced difficulty in a Western country like Canada. I actually faced the more difficulty in Canada to interview policymakers in government than I did in Lebanon. Because in the Arab culture, when you have an in, you have an in. So they will, like, if somebody knows somebody, they will get you that interview. In Canada, it doesn't matter if you have an in. If it's a no across the board.
That's a really good point. Thank you. So I want to turn to a question from our Q&A from Cesar Vargas. He asks, how can we beware of the potential colonialism in the scientific literature and its claim on the generalizability and the translation of evidence into local context and small specific communities? So that's not a small question at all. It's a huge thing that we all grapple with, I think. And I think it's some of what you were talking a little bit about, Ferez, around language. So I'm going to open that up to whoever would like to answer it. Who'd like to take that one on first?
I mean, it's a heavy question. I think that's why a lot of us are hesitant to, how do we do it justice in a short time? So I'm going to refrain from trying to answer this one.
So maybe I can just say a few words. So in my study, what I did was that I was actually very careful about generalization. And I really tried to not infer generalization on the broader population, and I really just tried to stick to the villages where I conducted the data collections. So I think that was my way of trying to be careful about potential colonialism of the scientific literature. But it is an important topic for sure.
Shakira, do you have something to add?
Yeah, I mean, that's a huge question, and hi to Caesar, because I've only ever met him on Twitter. So, I can't really sort of answer that question specifically, but what I could speak to is quite interesting. So when we're talking about colonialization, we're often talking about, the Western sort of narrative that is enforced on people and trying to break that. And so what's also interesting when it comes to comprehensive sexuality education, and it's come up in a lot of the consultations, especially from religious leaders, teachers, and parents, and they keep saying, you're coming with your Western UN ideas. And so that's interesting. So sometimes, there's pros and cons to the debate. The evidence is not that this is a Western phenomena, but that young people need it. But then it's also used as a counter argument, and it's really hard to get around. So just wanted to mention that.
So I've got one last question and then we'll wrap up, and I'm going to turn to Irene for this. So how do you think our field of researchers and journalists and academics and practitioners could better prepare to defend controversial evidence? I think your background as a journalist can help us answer that.
Okay, well, I think it's a matter of working together. I mean, as you listen in my presentation, journalists usually are not based into science, and scientists are not always based into communication. So we need to work together as a whole unit in order to get to people. And it is also an issue that happens into politics as well. And the reason I'm addressing about what happens when we get into politics is that science is getting politicized a lot nowadays. And it happened in my country like in May or April when all these COVID-19 issues were happening and we don't know it. We didn't know, well, we still don't know much about the virus, but back then we knew even less. And Costa Rica government was telling us, we're going to make our own diagnosis test because we can do it. And we will have our own big test diagnosing mechanisms in just 1 month. And what happened? The president of Costa Rica was addressing this message. And what happens when your president is addressing a message that has not scientific background? And yes, you can have all the scientific background and all the science people to do so, but not in such a small amount of space of time. I mean, just a month for a huge complete diagnostic mechanism. So what happened? That all my colleagues were reporting on that, and just people who were aware of what was going on with science could just get inquisitive and ask, how come you're promising this? And that was people who got to work with scientists. So we need to work together as a whole. We need journalists as well as a whole need to look forward to scientists, and scientists need to work with communicators so that we just can have this merge and have a better communication for people. Because in the meantime, at the end of the day, we're working for the people, we're working for populations, and we need them to have a better health. And the only way we can get a good health is with good collaboration and good communication, because people need to make decisions and they need to make them with good evidence. And good evidence needs to be communicated.
I think that's a good final thought for us, the value of coordination and collaboration and ensuring that we're working together. I want to thank Health Systems Global for providing us with the space to tell these stories and talk about controversial evidence and misrepresentation. I want to thank our 7 panelists today for being willing to share their stories in light of some of the controversy that they've managed to be that they've both ginned up and have been embroiled in for the last couple of years of their professional lives. I also want to thank my co-chairs, Daniela Rodriguez and Nazreen Jassani, for ably manning our Twitter chat today and ensuring that the information from our session lives on. As I said, my name's Taylor Williamson, and thank you again for joining us. Take care.